Good day, everyone. My name is Ogechi Sylvia Eze. I'm a general practitioner in Derby, which is a town in the United Kingdom. I want to thank Dr. Okechukwu for the opportunity to give this talk on antenatal care and its benefits. For the purposes of this talk, I have made some notes, so if you find my eye deviating to the left, I'm just trying to make references to my notes. It's a vast topic, so I've tried to divide it into three major sections, or four. These are definition of antenatal care, the benefits, what to expect, and interventions if needed. So, antenatal care is the can be defined as the monitoring um, or the care given by healthcare professionals to pregnant women for the duration of their pregnancy. Um, Most times people ask why antenatal care, knowing that pregnancy is not a disease, and there's a push to move away from medicalizing pregnancy. Um, the answer to that why would be the benefits or the purpose of antenatal care. I would list them about four, but when I go into what to expect, you might understand it better because the timings do vary. So, for the benefits, we could say one, it is for it helps us to monitor the progress of the pregnancy, and this is beneficial to both the woman as well as the baby. It's an opportunity for the healthcare professional to discuss and bond with the patient and give useful advice on healthy eating, exercise, as well as check up on their mental health. And then it is also an avenue for the patient or for the pregnant woman to discuss her choices. Does she want to have a natural birth? Does she want to have a cesarean section? Where would she want to have her baby? Would she want to have the baby at home? Because in the UK here, home birth is an option. Um, and then, in case she would need to have a cesarean section, let's say further down the pregnancy, if that is indicated, that can be discussed with the patient. So, those are some of the brief, should I say, the benefits in brief. Now, if we go into what to expect, I will divide that into you would have consultations, you would have physical examinations, and then you would have investigations. This can be divided into invasive investigations, and when I mean invasive, that's like having a blood test, and then non-invasive investigations, which include urine tests and ultrasound scans. So I will talk about my own experience as a general practitioner in the UK. This might apply to some of us in the audience, this might not apply, but then it is more or less an overview of what antenatal care involves. Um, so when a woman finds out she's pregnant, she's done a urine pregnancy test or she's missed her period and she's done a test and she finds out she's pregnant, the woman is advised to book an appointment with her GP. We will repeat the test if necessary, and then from the patient's first day of her last menstrual period, we'll calculate how many weeks she is. The patient, or sorry for using the word patient, the lady is then referred to the midwife who does the bulk of the antenatal care. And her first visit is called the booking visit. That visit is usually advised to be done between 8 to 10 weeks of pregnancy. So the booking visit is the first antenatal visit with the midwife. And now, I just need to mention that for ladies who are pregnant for the first time, they're entitled to 10 antenatal visits, while ladies who have been pregnant before are entitled to 7. I did mention that the midwife does the bulk of the antenatal care, but then it is a multidisciplinary approach whereby you have the general practitioner, the midwife. If these patients have got pre existing conditions, for example, she's hypertensive or they've got mental health issues, then other consultants are involved. The social worker can also be involved where there are concerns in the home or other, social issues, for example, homelessness, alcoholism. The social workers would be involved. So if we go into what is done during the antenatal care or the antenatal um, monitoring. So I said the first visit is at 8 to 10 weeks. That is when the patient or the lady sees the midwife. At that visit, the midwife will do the blood pressure, and she would also do her body mass index, which is a record of height and weight. The reason for doing the blood pressure is to give us a baseline blood pressure. If it's normal, that's fine. If the blood pressure is found to be high at that visit, it will be checked again to find out if this patient is hypertensive. And if the patient is, they are put on medications that are safe in pregnancy. If this lady was hypertensive before falling pregnant, then we need to find out what medication she's on, because this needs to be changed to a safer alternative. And another reason for doing the blood pressure is some ladies are at risk of preeclampsia, which is a condition associated with very raised blood pressure in pregnancy. So the baseline gives us a benchmark for monitoring. So blood pressure is done, body mass index is done. Body mass index because ladies who are obese are at risk of complications like blood clots, which is thickened blood clots in the legs or in the lungs. They are also at risk of premature labor. And then ladies who are underweight are at risk of poor maternal outcomes. Then the urine dipstick is done, and the purpose of doing the urine dipstick is to check for protein, because high protein in urine could also be pointing towards preeclampsia, but that is later in pregnancy. And then blood tests are done. The three major screenings in pregnancy are HIV, syphilis, and hepatitis B. And this is because these three viruses can actually be transmitted from mother to baby. Also, blood tests are done to know the blood group of the lady, as well as her rhesus status, and then also to know her hemoglobin, baseline bloods, and also her blood sugars, because we need to know if this lady has got gestational diabetes. If so, we can manage that. If she's anemic, she can be put on iron tablets. And then knowing her blood group is important just in case if she bleeds excessively in pregnancy and she would need to have a transfusion. The rhesus status, we need to know that because the baby could be at risk. The baby could form antibodies, and that could actually affect the pregnancy. So that is what is done at the first appointment, which is the booking appointment. Now, the lady also would have ultrasound scans. In England, pregnant women are entitled to 2 basic ultrasound scans. The first one is done at 16 to, my apologies. The first scan is done at 12 weeks. We call that the dating scan. So that scan tells us, it helps us to determine how old this pregnancy is. And from there, we can determine the expected date of delivery. The second scan is done at 20 weeks. And that scan is what we call a developmental scan to tell us how well the baby is forming. The heart, the lungs, the brain, the bone length, and also as an opportunity to screen for any abnormalities. Some people request to know the sex of their baby. You could discuss that with the sonographer or when you go for that. Now, we go to the frequency of antenatal visits. So I've mentioned the 8 week, which is booking, and then there is another visit at 16 weeks. This is the second one. And at this visit, the midwife goes through the bloods, finds out if the patient is anemic, if the patient is diabetic. These would be referred on to the GP to action. Now, the next visit would be at the 20 weeks, which is for the ultrasound scan, which I mentioned before. And I've also talked about the reason why this scan is done. Another reason why this ultrasound scan is done is to find out the position of the placenta. If the placenta is low lying, especially if it remains low lying towards the later parts of pregnancy, then there is an increased chance that the lady would need to have a cesarean section as against a natural delivery because of risks of bleeding massively from the placenta. Then the fourth visit is at 25 weeks. At 25 weeks, the midwife, in addition to blood pressure, weight, she will measure the height of the uterus. This is usually from the pubic bone to the highest point of the uterus, and it's measured with a tape measure. This should correspond to the age of the pregnancy plus minus 2. If it's too low, then there's a risk of the baby not growing well. If it's too high, then there's a risk of a very big baby, or there is excessive fluid, amniotic fluid, inside the uterus, and proper intervention needs to be made at this point. So I'll talk about the fourth visit. Now, from the 25th week, the subsequent visits you have more or less the same thing being done, which include height, weight, and the uterine height, measuring the uterine height to make sure that the baby is growing adequately. And this is usually plotted on a graph to be sure that the baby is growing well. If there's any deviation from there, we need to intervene at that point in time. So at 28 weeks is the fundal height, and then the lady who is rhesus negative would receive her first injection of anti-D, which people call Rogam. At 31 weeks, the same thing is done, but no more anti-D at this time. Then at 34 weeks, the midwife begins to discuss with the lady about her labor options. What does she want? Does she want to have a natural birth? Some people opt for an elective cesarean section. And the lady can also decide if she wants to have a birthing partner with her. Does she want it to be her husband, partner? Does she want it to be a family member? And at 34 weeks, she also receives her second shot of anti-D for the ladies who are rhesus negative. At 36 weeks, there is the option to discuss feeding methods. Breastfeeding. Some ladies opt for bottle feeding, and this can also be discussed as well. And then trying to bring the lady into terms with becoming a mother, so caring for her baby, asking about her health, because pregnancy could take its toll on a lady's mental health. So how is she feeling? Any symptoms of depression, anxiety, her sleep, and also what support does she have at home if need be. So that is at 36 weeks. So the next would be at 38 weeks. Delivery options are discussed again, and then if the lady has any further concerns, she can also discuss it with her midwife. At 40 weeks, the same thing is done. At 41 weeks, the midwife would offer the lady a membrane sweep. The membrane sweep is done by inserting 2 gloved fingers into the neck of the womb through the vagina and running it around the cervix to release the membranes. And What this does is to induce labor naturally, if I should put it like that. Now, the that's at 41 weeks. The 10th visit will be at 42 weeks if the lady has not gone into labor. Most times, there is more discussion about going for a cesarean section. Some ladies refuse to have a cesarean section, and we have to discuss the advantages and disadvantages of allowing this pregnancy continue. Um, if the lady refuses and has capacity, then she has to be monitored even more closely. So, in summary, antenatal care gives healthcare professionals the opportunity to monitor pregnant ladies and their babies, to pick up any abnormalities early, one, to educate the patient on what they can do to remain healthy and to prevent any um, complications in pregnancy. And it also gives us an opportunity to form a lasting bond with this patient and their baby, as well with the lady and her baby, as well as with her family at large. Um, I hope I've been able to give an overview of what antenatal care is. Um, Also, with like I've said that much earlier, healthy eating and exercise. Um, Physiotherapists are also involved in case the lady begins to get some pelvic pain, back pain, then they could be given exercises to do to relieve these symptoms. Um, yeah, if you've got any other questions, please either direct them to me or direct them to Dr. Okechukwu, who will clarify further. Thank you very much.